Hello, I'm Pennan, and today I'll be talking about multidrug-resistant tuberculosis aspects of diagnosis. Well, I thought we should start with some terminology, just a review, because this is important when considering diagnoses. First, monoresistant TB is TB that's resistant to only one drug. Polyresistant TB is TB that's resistant to more than one drug, but not the combination of INH and rifampin. Multidrug-resistant TB is TB that's resistant to at least INH and rifampin. And then we have some additional categories that are multidrug-resistant TB with additional resistance. So pre-extensively drug-resistant TB, or pre-XDR-TB, is MDR plus resistance to fluoroquinolone or a second-line injectable. That includes amikacin, kanamycin, or capreomycin, but not both. If you're resistant to both fluoroquinolone and an injectable, that's called extensively drug-resistant TB, or XDR-TB. Again, that's MDR-TB plus resistance to the fluoroquinolone and at least one second-line injectable agent. Well, of course, first, in terms of diagnosis, the first task is recognizing when there's a risk of MDR-TB. So I'll be talking about several of these risks. The first set on this slide are, I think, important to keep in mind. So history of previous TB treatment, particularly if that treatment has been recent. Known exposure to an MDR-TB case, of course, is a risk factor for MDR-TB. HIV positivity is historically a risk factor for MDR-TB and is included in every guideline, and that's because of a higher incidence of rifampin monoresistance, which can lead to subsequent development of MDR-TB. There's also poor response to standard 4-drug treatment. The definition of poor response is typically when a culture remains positive after 2 months of treatment. Typically, this is where MDR-TB or acquired drug resistance will be included in the considerations of what to do at 2 months when the culture remains positive, among several other things, such as making sure that directly observed therapy has been going as expected, that the patient's taking the medication and absorbing the medications. But MDR-TB is a risk in this situation as well. Additionally, on this slide are some other epidemiologic risk factors for MDR-TB. Here, we're including persons who are not U.S. born, who have arrived in the U.S. within the last 2 years or so. In addition, persons who have immigrated from or have had recent extended travel to a country where there are more than 2% MDR-TB among cases diagnosed in California or the U.S. Currently, these countries are India, Korea, Burma, Laos, Peru, Ecuador, Russia, or other former Soviet states, Central America, and Dominican Republic. Certainly you can visit the CDC website and the California Department of Public Health website for updated information on these countries. In addition, at least in California, but I think this is beyond California, there are other state or locally identified risk groups that include Hmong refugees or persons of Tibetan origin, which would also be considered to be a risk factor for MDR-TB. So when you identify one of these risk factors, what should you do? First, I think the thing that can get results fastest is to obtain a molecular test for drug resistance. There are several of those available, and I'll be talking about those more in subsequent slides. But briefly, I think the widestly available assay is the Expert MTB RIF assay. There are also some other sequencing-based tests, such as pyrosequencing or Sanger sequencing. There's the Hein line probe test, and there's two of those, and there may be other laboratory-developed tests that you have access to. Additionally, you could consider initiating an expanded regimen for drug-resistant TB. I will say that this is pretty rare in the era of molecular testing. We're almost always able to get some additional information pretty quickly. However, in rare situations, such as when you have a contact of an MDR-TB case who now has active TB, or an immigrant with a history of extensive treatment for TB in the past and again has active TB, so you're really thinking that MDR-TB is likely. Or in certain situations when you think it's going to be an extended time for you to get resistance information and the patient is not clinically stable enough to wait for results. Those might be situations when you might consider expanding empirically, giving a broader regimen beyond the standard therapy without having evidence of drug-resistant TB. Well, now I'll be talking more extensively about molecular testing for drug resistance. So first, let's talk about the different types of tests for drug resistance. I like to divide them up into non-sequencing based tests and sequencing based tests, principally because the type of information that you can get from these types of assays are slightly different. Non-sequencing based tests are tests that report the presence of a mutation but don't tell you specifically what that mutation is. Examples of these assays are molecular beacons-based assays. That would be molecular beacons-based assays, principally, again, the Cepheid Expert MTB RIF assay, which is FDA authorized. There are some other tests based on line probes, the Hein MTB-DR Plus and MTB-DR-SL, as well as the InnoGenetics InnoLIPA RIF-TB assay. None of these assays are available routinely in the United States, however, some labs do perform them. In addition, there are laboratory-developed tests that also might be non-sequencing based tests. Now, the sequencing-based tests, which report a specific mutation, include pyrosequencing, sometimes abbreviated PSQ, and CDC's molecular detection of drug resistance service uses both pyrosequencing and more traditional Sanger sequencing. And becoming more and more common, of course, is whole genome sequencing, which among the large amount of information provided can also provide the sequencing of drug resistance related genes. This table shows some of the data that's available on the performance of molecular testing by antimicrobial agent and by the gene or locus that is sequenced or tested for in various assays. So what I'd like you to get out of this slide is just the diversity of genes and loci that are able to be tested for drug resistance across many of our drugs. I'd also like you to see that the performance varies quite a bit in terms of sensitivity and specificity. In general, specificity is pretty good, but sensitivity varies quite a bit. Luckily, rifampin's sensitivity is the highest on the list, and isoniazid is a little bit lower, and you can see the performance for the other drugs as well. The right-hand column, I've tried to include what assays these genes are tested for, so you know a little bit more about where to go to get these tests performed. I'm going to pause briefly and talk about the types of mutations that are encountered, just as a little bit of a review. First, there's silent, or sometimes called synonymous mutations. These are mutations that include a nucleic acid change, but no change in the amino acid sequence. So the underlying DNA code will be slightly different, but the protein that is made from that DNA code is not different. Now, this kind of mutation is not associated with drug resistance generally. And here on the slide, I'm mentioning the most common silent mutation in the RPOB gene at codon 514, and I'll be coming back to that in future slides. Now, another type of mutation is the missense or non-synonymous mutations. Now, this is where there's an underlying nucleic acid change, and that results in a change in the amino acid as well as the protein that is translated from the nucleic acid. Some of these mutations are associated with resistance, but not all. Well, I've talked a little bit already today about molecular testing for rifampin, which focuses on the RPOB gene. This is the test that's most widely available to you through the Cepheid Expert MTB RIF assay. And you might wonder, well, why is there a lot of focus on rifampin in molecular testing? And that's for a couple of reasons. Rifampin, one, is the cornerstone of our TB treatment, which means that if there's resistance, that the patient will need to be treated for a much longer time. And rifampin resistance without INH resistance is rare. And so for at least purposes of designing initial therapy, rifampin resistance should be considered to be MDR-TB until proven otherwise. Here is a schematic of the Expert MTB RIF assay. Now, this assay focuses on this 81 base pair region of the RPOB gene, and those you can see in the DNA code letters. They're running on either side of the numbers. The numbers in the center correspond to the codons of the RPOB gene. Now, these numbers are the E. coli numbering system, not the MTB numbering system. You can see that the Expert assay consists of 5 different probes A through E, and each probe is able to identify when a mutation occurs in that area, but not which mutation specifically is identified. Now, if I put out these black arrows, these are places where the most common mutations in RPOB that confer resistance are found. And you can see that these mutations occur throughout all 5 probes, but the most common probe and the most common resistance mutation is found at codon 531 in probe E. Now, if I put up the silent mutations, you can see in blue here that they occur in a number of different probes, but the most common silent mutation is found at codon 514. That's in probe B. So you can see that if you ask your laboratory to tell you which probe is the one that's providing the rifampin resistance result for your Expert test, you could get a clue about whether or not that result is likely to be the result of a silent mutation or not. However, you can see that in probe B there are also mutations that do confer resistance. So that information is not definitive, but can give you a clue while you're awaiting more information. Certainly that is a message from this talk, that when you have a molecular test that's based on a non-sequencing based assay, it's important to confirm that result with a sequencing based assay, and certainly ultimately culture-based drug susceptibility testing. So in the laboratory, this is what the laboratorians see when they run the Expert test. This is not information that you will get on your laboratory report, but I think it's useful to know what information the laboratory may have available. So I'm going to blow this up. First is the test result. It shows that MTB is detected, and also in this example that rifampin resistance has also been detected. You can see here in an older version of the assay that it also gives an indication of how much organism is in the specimen. Here it's very low, but subsequent generations of the assay do not include that information, just that MTB is detected and whether or not rifampin resistance is detected. When I blew up the curves here, you can see a little bit more information. And how the assay works is it looks for a probe that drops out, that does not amplify, meaning you don't see these colored lines that are going up across the screen, indicating that there is a DNA sequence there at that probe that the probe is identifying. In this example, probe A, designated by the brown line, and in the brown box is the one that does not have any amplification. And so in this example, the mutation is going to be present in probe A. So just again, these calling and discussing with your laboratory what additional information might be available can be helpful. One, they can give you a sense of how much DNA there likely is present in the specimen, as well as which probe has quote-unquote lit up and giving you the rifampin resistant result. Well, expert performance for rifampin resistance is here. These are data from a Cochrane review in 2014 showing that the median sensitivity for rifampin resistance is 95%, so pretty good. Pooled median specificity is 98%. I believe the package insert for expert has a specificity of 99%. So again, a pretty good test. But what I'd like to use these numbers to demonstrate is that even with a high specificity, for an assay that is trying to identify a rare result, that the positive predictive value of your result may be relatively low. So on this table, I'm showing the number and proportion of MDR-TB by country or region of origin for California cases diagnosed between 2011 and 2015. And I've ordered this table by percent MDR by country of origin, range from the top, the former Soviet republics at 12%, down to Mexico with 0.6%. Now when I put the positive predictive value numbers in the columns to the right, including both 99% and 98% specificity, and what you can see is that you get down to 50% positive predictive value quite quickly, and 98% specificity right there at the 2% cutoff. And so that's why we often use that threshold to define MDR-TB risk. Now if you look at the countries here, you can see that that all makes some sense. However, most MDR cases come from or occur among persons who are born in countries below that 2% threshold. So specifically Philippines, Vietnam, Mexico, and the United States are all there with higher numbers of MDR cases, but lower proportions of cases with MDR. So that's an important thing to think about when you're looking at an expert result that shows rifampin resistance. So here in the yellow box is this threshold of 2%, which keeps the positive predictive value above 50%. So one additional way to think about these data is if I include the time since arrival in the United States. So that's what I'm showing here. Again, this is the proportion of cases that are MDR, but now divided by persons who have arrived within the last 2 years or more than 2 years. And what you can see here is that 3 countries that have quite a number of MDR cases, but a lower proportion of MDR cases overall. You can see that when restricted to recent arrivers, that the proportion that are MDR rises above that threshold of 2%. And so again, this is helpful when thinking about how to interpret a rifampin-resistant result, and also the reason that one of my first slides included recent arrival in the United States as a risk factor for MDR-TB. What I've showed you up to this point is data for California. Here is data for United States as a whole, with a little bit of a different time period, 2010 to 2013, but the overall message is the same, that certain countries or persons from certain countries may have differing risks of MDR-TB when diagnosed with TB. Well, now thinking about this introduction to expert and these data that I've shown you, I'd just like to show some examples about how to interpret results of molecular tests for resistance. And I'll do that with a couple of cases. So here's case number 1. This is a 70-year-old asymptomatic man from India who you're seeing in clinic with an abnormal pre-immigration chest x-ray, but no history of TB treatment or diagnosis in the past. Now, a subsequent chest x-ray done after arrival in the United States is read with multifocal infiltrates. A sputum was obtained and is smear positive on 3 different specimens, and in fact an expert assay was run showing rifampin resistance. So the question is, in this scenario, what would you do next? And you can do more than one of these things. Start MDR treatment, order pyrosequencing or MDDR. Those are sequencing-based assays for drug susceptibilities. You could start standard 4-drug therapy for TB. You could repeat the expert on another specimen to confirm, or you could start treatment for monorifampin resistance. Now, if you want, you can pause the video and consider your options. I'm going to move on and say that I think in this situation, with a person from India with a pretty convincing at this point diagnosis of TB, that'd be a pretty convincing diagnosis of TB with expert positive, smear positive sputum from a country where MDR is greater than 2%, that I would tend to believe this expert result of rifampin resistance. I could start MDR treatment right away in this situation. Often we can get the sequencing-based assay results quite quickly, and so many times you can actually wait to start MDR treatment until you get a pyrosequencing or MDDR assay result back. However, sometimes there is a delay in that, or the patient is not clinically stable and you want to start MDR treatment right away, and I think you could do that as well in this patient. So in this situation, treatment for this patient was initially held. Pyrosequencing was available within 2 days and the patient was clinically stable, so that seemed clinically appropriate to do. The pyrosequencing results are here. You can see that there was a CAT-G mutation found that confers INH resistance. In addition, the RPOB mutation was that common 531 mutation conferring rifampin resistance. So confirming here by molecular tests that this is MDR-TB. Thankfully, in this situation, there were no mutations associated with fluoroquinoline resistance in the GYR-A gene or in the RRS gene conferring resistance to injectables, particularly amikacin. So that's very helpful moving forward to construct your regimen. You probably don't have to worry about XDR or pre-XDR in this patient based on these molecular results. Of course, that should be confirmed with culture-based drug susceptibility tests. So at this point, what would you do now? You think you have enough information to start MDR treatment? Do you need to order MDDR, which is another sequencing-based assay? Maybe you want to wait for the culture-based drug susceptibility test and start 4-drug therapy. You want to repeat the expert on another specimen just to confirm, like, this is a pretty big deal, and you want to make sure that this is the diagnosis. Would you want to order second-line drug susceptibility tests? Or maybe you could go the other direction and say, you know what, I have all the information that I need now. Actually, I can cancel any additional assays at this point. So again, think about which of these you can choose more than one. In this situation, what I would suggest makes sense is I think you do have enough information now. You can start MDR treatment. I don't think you have to order MDDR from CDC, although there are advantages to doing that. Chiefly that that service from CDC is a place where you can get molecular results for ethambutol and pyrazinamide, and that can be helpful in designing your initial treatment. I would say it's incredibly important at this point to order second-line drug susceptibility tests. Most labs will not order those or will not perform those on a reflex basis until first-line resistance has been shown in culture-based drug susceptibility tests. And so you can get a jump on ordering these second-line drug susceptibility tests if you order them based on the molecular results. So in this situation, these are the options that I think are reasonable. The differences between case 1 and case 2 are that this is a man from Mexico, identical presentation and microbiology and radiographic results. However, this person is from Mexico and is not a recent arriver in the United States. So based on the data that I showed earlier, the proportion or the risk of MDR-TB in this patient is going to be less than 2%. And so I think it does make sense to order pyrosequencing and MDDR or MDDR here to confirm with the sequencing-based assay this non-sequencing-based result. I think here you could start for standard 4-drug therapy because the positive predictive value of this assay is likely lower than 50%. I think that will depend a little bit on the specific clinical situation and how ill this patient might be, but I think that is reasonable. So in this case, that is what happened. Standard 4-drug therapy was started. Suspicion for MDR-TB was low, and in fact, pyrosequencing results confirmed that. There was no mutation conferring INH resistance, and in fact, the RPOB mutation that was identified in probe B was the most common silent mutation at codon 514. So I think these two cases illustrate some of the thought process that you should go through when interpreting a rifampin-resistant result from expert or any other non-sequencing based molecular test for drug resistance. Again, I think you need to put these results into clinical and epidemiologic context. Think about what the risks for MDR-TB are. Again, confirm a non-sequencing based test with a sequencing-based test. When you get rifampin resistance, think about that not as rifampin monoresistance, but think about that as MDR-TB until proven otherwise. And I think with our molecular tests, we can usually treat based on the sequencing-based test results and can then follow the growth-based DST results and make modifications based on those results down the road. There are, of course, some limitations and areas for caution when thinking about and interpreting molecular tests. Chief among these are you will often or commonly encounter some discordance between molecular tests and the culture-based standard drug susceptibility tests. There are a number of reasons that there can be discordance. One is that there can be undescribed mutations outside the loci that we are looking at in our current molecular tests that can confer resistance. So the molecular test will show no mutation, and you would interpret that traditionally as susceptibility, and yet you get the drug susceptibility test back and it shows resistance. Another way that there's discordance is when there's emerging resistance in a mixed population, and when the minority population is the resistant population, that may not be picked up by the molecular assay. Additionally, there are some mutations in the RPOB gene specifically that have been called in the literature disputed mutations. And these are mutations where the molecular assay shows a mutation, but the traditional drug susceptibility testing results as susceptible. However, in clinical series, patients with INH resistance and a disputed mutation have been found to have higher rates of clinical treatment failure. And so in our practice, we typically treat those patients with an MDR-like regimen. Well, that rounds out my discussion for today on MDR diagnosis. I'd like to acknowledge my colleagues from the California MDR-TB service pictured here, and I'll just finish up with some MDR-TB resources that might be helpful when thinking about MDR management and MDR diagnosis. Thank you.